Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to go through a paper from the Journal of Osteopathic Medicine. This is it was published October 13th, 2021. It is in an edition, I think it's a 2022 edition of the Journal of Osteopathic Medicine. The title is Evaluating for a Correlation Between Osteopathic Examination and Ultrasonography on Thoracic Spine Asymmetry. I'm going to try to go through pieces of the paper. I don't think it's absolutely valuable to go through every single piece, as I often do with other papers, but there's some value in understanding what's going on here. So fundamentally, one of the aims is agreement on identification of a thing and the ability to name it specifically within a patient. That is something that seems to hold value or be seen as valuable within osteopathic hands-on therapy, or osteopathic manual therapy, osteopathic manual manipulation, osteopathic manual medicine, whatever term you prefer. Please excuse me for just someone. Excuse me, just had to clear some stuff. So because there is a consideration of value, something is believed to be valuable, then when you notice that you're not doing a great job of it, you try to improve it. One of the biggest deals is inter-rater or inter-examiner reliability, the ability for different examiners or different raters to find the same thing. If you can't find the same thing, you can't agree. You don't have a fundamental hold on what would be considered the singular reality because you can't both get there, or you don't agree that you got there. Each one of you thinks you're there, but neither one of you believes that the other one is there at that point. So fundamentally trying to get to the same reality, you have to assume that accurate identification, or specific identification, maybe a better term, is the thing that's valuable. Excuse me, my nose is running, and part of it is because, well, it's running inside. Part of it is because I just had lunch, and it was very tasty. Anyways, just to read the title again, Evaluating for a Correlation Between Osteopathic Examination and Ultrasonography on the Thoracic Spine Asymmetry. So one of the reasons I'm going to read specific pieces is because I want you to understand what they identify as thoracic spine asymmetry, which unfortunately I'm just not going to agree with on a basic level. Like, it's going to kind of make me giggle. Well, it did make me giggle, and maybe I'll giggle in front of you. Maybe I won't. It's kind of disrespectful. But anyways, oh gosh, I went too far. To get into this, thoracic spinal pain, although less common than lumbar and cervical spinal pain, can be disabling, with a prevalence of 13 to 15% in the general population. Consequently, the thoracic spine is a common area of focus in osteopathic medical schools and is an area of treatment focus utilizing osteopathic manipulative medicine, OMM, for a variety of conditions such as spinal rib dysfunctions, autonomic nervous system imbalances, and dermatological disease. If you're going to tell me that you're going to treat the autonomic nervous system because you worked in the thoracic region, I'm probably going to tell you that you don't understand how things actually function. Because things are physically close to one another doesn't mean that there is not affordance for them to not piss each other off. If movement of your ribs was going to give your autonomic nervous system a problem, then breathing would give your autonomic nervous system a problem. You could counter-argue and say that breathing generates rhythmic input so that automatically balances the autonomic nervous system. I just don't know if I'm buying it in that fashion. Just because things are close to one another doesn't mean they know each other or that they piss each other off. So that's just me going on a tangent that's not absolutely required, but I felt like it. To continue to read, the diagnosis of somatic dysfunction in OMM utilizes the common mnemonic TART, which stands for tissue texture, abnormality, asymmetry in bony positions, restricted range of motion, and tenderness to palpation. Thoracic spine somatic dysfunction diagnosis is achieved by palpating for asymmetry at the tips of the transverse processes, which I think is not smart, because the transverse processes are hidden by multiple layers of relatively dense and obscuring tissue, including multiple layers of erector mass, subcutaneous fat in the in the thoracic region, the likely reasonably developed trapezius. So yeah, this just doesn't seem like a smart thing. Also, the scapula kind of get in the way, depending on how the person's laying or presenting. Hold on. The asymmetry in bony positions can be palpated through identification of relationships among anatomical structures, and it is particularly applicable to complaints associated with rib or vertebral displacement. Just because this is cited doesn't mean I buy it. to read again, vertebral asymmetry is indicated by the side with a more posteriorly located transverse process, which also demonstrates the direction of vertebral rotation. I don't know if you've ever heard of bony asymmetry, but it's a real thing. It's not that hard to know if you have ever worked surgically or with any form of cadaver. Asymmetry is normal. Bony asymmetry is normal. You can see it in like a hand-drawn picture in a netter's, not because of low fidelity of reproduction, but because of high fidelity of reproduction by the artist. Accurate diagnosis and naming of somatic dysfunction can be challenging for the early osteopathic student, and inter-examiner reliability has been shown to be low even among advanced practitioners. Yes, they don't agree. The only thing you seem to be able to get them to agree on, if you make them do the exact same thing, is, I think it's tissue texture, right? So this thing is not as squishy as the other thing, and pain. But pain provocation is because you poke somebody in the ouchie and they tell you it's ouchie. So if you do it the same way and the person says it's ouchie, you tend to agree. To complicate matters further, the naming of each thoracic vertebral level follows the rule of threes from the model developed by Mitchell et al. What if it's not true? Like, what if this thing where the SP is versus where the transverse process is doesn't actually hold up in that particular individual? It's not bad. It's not a bad model. It's a decent generalization. But what if it's not true for that person? What are you going to do? How do you know? Whatever. Anyways, I feel spicier today. Maybe it's lunch. However, and also, let me just be clear, this is April 15th when I'm recording this, because I don't know how far out I am. I got stuff scheduled in July, I think. I'm sure I have stuff scheduled in July. Maybe I'll reorder the schedule, but if you hear this, thank you. Anyways. However, anatomical studies done by Oakley et al. And Gielhold et al., as well as radiographic studies, reveal that instead of following the rule of threes, TPs of a given thoracic vertebrae generally align with the spinous process of the vertebrae above. Oh, who knew? A model, a generalization, doesn't hold up to actual scrutiny in osteopathy. Who knew? It's not like I haven't been saying that for years. Yeah. Although there has been an in vivo study conducted that reveals the gross motion of the thoracic spine to our knowledge. Huh? What? No, oh, there we go. Sorry. There's just a writing quirk, or at least a comprehension quirk on my part to read again. Although there has been an in vivo study conducted that reveals the gross motion of the thoracic spine, to our knowledge, no in vivo study has discussed the anatomical positional alignment of the transverse process with the spinous process in the thoracic spine. Okay, there we go. I read that properly. Ultrasonography can be utilized to visualize and to objectively measure the relationship between neighboring anatomical structures. Musculoskeletal ultrasonography has been widely utilized as a diagnostic tool to monitor conditions of soft tissues, joints, ligaments, and cartilage. Ultrasonography has the advantage of absence of ionizing radiation, has shown comparable results to gold standard modalities like MRI in some areas of the spine. Although ultrasonography can have limitations in that the examiner must have sufficient anatomical knowledge and proper training prior to scanning, ultrasonography has been shown as a reliable modality to identify SPs and TPs of spinous processes and transverse processes of the spine. In the case of thoracic somatic dysfunction, ultrasound can penetrate through multiple layers of soft tissue to visualize the bony features as distinct hyperechoic signals, which can be utilized to determine the location of each vertebral transverse process and its relationship with neighboring bone features such as the SP. I'll read this part. Previous studies have investigated the relationship between OMM and ultrasonography of the cervical, lumbar, and sacral regions. However, to our knowledge, no study has compared osteopathic structural examination with ultrasonographic examination of the thoracic vertebral region. In this preliminary study, the authors seek to explore and compare osteopathic palpatory findings of thoracic TPs with ultrasound measurements when evaluating for thoracic vertebral asymmetry. We hope to create a study design utilizing inter-examiner agreement and correlation to examine the relationship between osteopathic palpation and ultrasonographic measurements of the thoracic spine. So if you have ultrasound, one would hope that you can become more accurate with the identification of stuff. They do note that the skill of the person using the ultrasound makes a difference, especially their understanding of not only the tool, but the anatomy. It matters. It makes a difference. So whatever. To read methods, the study was registered with clinicaltrials.gov, and the study identifier, whatever. Study protocol was approved by Midwestern University Institutional Review Board at the Glendale, Arizona campus, and the participants provided written informed consent. The study did not require any funding. The study actively recruited subjects between October 10th, 2019 and January 30th, 2020. Email announcements were sent to students at the Arizona College of Osteopathic Medicine and the Masters in Biomedical Science program at MW in Glendale, Arizona. I don't need to read that. Setup and landmarking. I'll do the setup. Subjects were seated upright in stable chairs with substantial lumbar support, with the back of the chairs below the level of a T7 SP. I don't know how you know that. I think you're making a guess. Maybe you're not making a guess. Who knows? If you say below, maybe you tried to put it at T12. Each subject was placed in an individual room next to an ultrasound machine and could not communicate with each other while the study was in session. Each examiner was blinded and could not communicate with each other or see what the other examiner was performing throughout the entirety of the data collection phase. There was a data collector stationed at each subject area to record all data, which were blinded from the examiners. Marking of landmarks on the skin were performed by an OMM scholar. Members of the OMM scholarship program are osteopathic students selected through a competitive evaluation system to become peer instructors within the Department of Osteopathic Family and Community Medicine. The OMM scholar in this study was a fourth-year medical student who was in her second year of teaching structural palpation, osteopathic diagnosis, and treatment techniques to first and second year medical students. So they're setting up that the person doing this has some level of skill, right? They're proxy, so length of time doing things is a proxy and an assumption about level of skill, but it doesn't sound bad. The OMM scholar palpated subjects' upper backs on the skin and gave verbal instructions such as look down, look up to the ceiling to obtain accurate determination of each SP. First, the C7 SP bony protrusion was identified utilizing non-toxic, non-permanent skin marking pen. Then, subsequent thoracic SPs of T1 to T4 were palpated and marked. To mark the TP transverse process, the marker is placed at a distance 1/2 inch directly lateral to each SP. Then each transverse process is marked with a number of the vertebrae below. The number 3 is written to indicate TP of T3 until the T5 transverse processes were marked. All vertebral segments indicated in the study, if not otherwise indicated, refer to the transverse processes of each vertebrae. T3, whatever. We have decided to focus on T3 to T5 vertebrae to limit interference from other anatomical structures. Understandable. I don't know if they left that on. Maybe they did that after. Did they do that after? I don't know if they did that before or after. Anyways, to read again, the OMM structural exam. The main motion of the thoracic spine is rotation. The range of motion for side bending, flexion, and extension is limited by the rib cage. Furthermore, small rotatory movements are permitted between the adjacent vertebrae due to the position of the SP. Therefore, to ensure reproducibility with the ultrasound protocol, and given that the major motion of each thoracic vertebrae is rotation, the OMM structural exam focuses on the rotational component of the thoracic spine somatic dysfunction. So they're looking at rotation. To read again, 2 osteopathic physicians who are neuromuscular skeletal medicine NMM certified by the American Osteopathic Board of Nuclear Medicine, AOBNM. What? That's interesting. Performed the osteopathic structural exam portion of the study. Both were OMM faculty members teaching at MW at the time of the research data collection. Multiple training sessions were conducted prior to the data collection phase. So they actually did some training, some palpatory training so that they were doing the same thing. That's actually good. That's fantastic. 2 examiners conducted the exam to minimize single examiner bias. Prior to each data collection session, the protocol was reviewed by the examiners, so standardizing process. That's fantastic. Each subject was asked to sit straight up and to look straight ahead at a far point on the wall. The exam was performed at the T2 to T5 transverse process region in the neutral spine position initially. Examiners utilized the marked spots as a guide and palpated marked transverse processes on the skin. So they actually pre-identified. So there we go. That's why they pre-identified the levels. So they told you where it was, and then they asked you what it was doing. Okay, that's fair enough. Awesome. First, examiner palpated each vertebrae from T2 to T5 to determine a left or right rotation by palpating for a more posteriorly rotated transverse process or a speed bump, i.e. the side that had more noticeable hard or bony protrusion feel. Then the examiner assessed which transverse processes were rotated based on palpation. To ensure that the protocol is as similar to the ultrasonography protocol as possible, and to prevent the possibility that a somatic dysfunction may be corrected during the structural exam, motion testing through neck flexion and extension was only introduced to confirm findings when the examiner felt absolutely necessary. Finally, the physician identified the most prominently rotated vertebrae that is clinically treatable for each subject. Once the first examiner had completed the exam, a second examiner repeated the above steps on the same subject. The OMM portion was complete after both OMM physicians concluded their structural exam. During data collection, the osteopathic physicians were blinded to the examination findings of each other and the findings of the sonographers. So, just kind of run your thumbs down, find the area, whichever one feels firmer or more posterior to you, and then using the neck to confirm. So using the neck to try to induce rotation from above and then find resistance. Unfortunately, I don't necessarily agree with how that would work. What I would want to know, or what would probably make it more apparent, would be to have the person rotate as far as they freely can and palpate at that point, in that kind of end point, in both directions, and identify which ones don't come back. Because if you're looking at osteopathic terminology, it is not the one that is positionally found or found as asymmetrical without movement. It is the one that is found asymmetrical with movement. So the preference would actually be to induce the movement and find the one that does not rotate a particular direction and call it rotated the opposite direction. So in osteopathy, if something will rotate to the right and will not rotate to the left, upon motion testing, you call that rotated right. What they did is they just left the person in neutral and either poked it or turned the head. So this is a static asymmetry primarily. Even if you use the head and the neck, you're not actually moving the thoracic column. You're just putting tension that runs from the neck into the back. It's probably not going to generate the rotation you would want it to. So as far as the actual examination, I'm not going to buy a ton that comes out of this as far as accuracy to movement dysfunction. But I will buy stuff with respect to inter-examiner reliability, because they're doing the same thing the same way. So inter-examiner reliability, this study design is fine, but actually figure out what's not moving. No, this isn't, because you didn't move it. You just poked it. Anyways, ultrasound exam, to read again. The ultrasound exam was performed by 2 sonographers after the completion of the OMM examination. One sonographer is certified by ARDMS in musculoskeletal, registered in musculoskeletal RMSK ultrasound. And the other sonographer is a longtime anatomy professor with extensive ultrasound training who has taught ultrasound to medical students as part of the anatomy and OMM curriculum since 2017 at MWU. The protocol was developed under supervision of the certified musculoskeletal U.S. specialist, or ultrasound specialist. Multiple training sessions were conducted prior. Yeah, so they did they've coordinated, they set up a protocol and probably followed it reasonably well. To read again, the scan was performed with curvilinear probes. In the transverse view, sonographers started by placing the probe at the T2 spinous process, which appeared as the most hyperechoic section at the top of the screen. After the T2 spinous process was visualized, the tip of the spinous process was confirmed by dropping the probe below the T2 spinous process until it was no longer visualized. Then the probe was moved back again until the tip of the T2 spinous process was visualized again. Then the probe was angled such that blah, 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 angle. Once the first sonographer was done, okay, there we go. The image was then frozen to measure the distance between each of the T3 transverse processes utilizing the caliper function of the ultrasound machine. This was repeated for T4 transverse processes and T5 transverse processes. Once the first sonographer was done, the process was repeated with the second sonographer. During data collection, the sonographers were blinded to the examination and findings of each other and the osteopathic physicians. Continuing to read. The integrated caliper function was utilized to determine the measurement from the center of SP to the tallest point, the lateral apex of the transverse process of the vertebral segment below on the right side of the screen first. The same process was repeated on the left side of the screen. The data were then recorded in centimeters. The lower measurement, smaller number, indicated the direction of rotation. I think I would have to understand more about how the image was developed, because I don't know if that's just asymmetry from midline or if it's asymmetry against a plane, right? So with something like this, you may be able to generate a plane of view and identify where something is within that plane. So like a Cartesian analysis with multiple axes. So you'd need at least 2 axes to figure this out, I think. I don't think you can have 3. I think you can more or less have 2 axes, like an up, down, left, right kind of deal. I don't know if you can have say an anterior, posterior. I don't know if this is just measuring asymmetry from midline, so a single axis, or if this is measuring 2 axes. I don't know, so I can't comment on that, but I would want it to do at least 2 axes. And if it does, cool. If not, then that's not going to tell me much. Statistical analysis, don't need to do that. The results, I'm not going to read it there. There's, basically, to sum up the results, the inter-rater reliability sucks for all of it, right? There's the Cohen's, what is it? Is it the Cohen's kappa? So Cohen's kappa interpretation, and this is in here in the table that's showing the inter-examiner agreement. The Cohen's kappa interpretation: 0.10 to 0.20, slight agreement 0.21 to 0.40, fair agreement 0.41 to 0.60, moderate agreement 0.61 to 0.80, substantial agreement 0.81 to 0.99, near perfect agreement, confidence interval, OMM, osteopathic manipulation, whatever. That's just the things they're doing. So the highest level of agreement that they got for anything was between the ultrasounds, and that was 0.27. So, we're not doing so good. 51.5% of the time they agreed on the rotation that was identified with ultrasound, and that's the best that happened. Ultrasound versus OMM, rater 1, 33% of the time. 0.02 Cohen's kappa. So just dog trash. It basically doesn't exist. There's no agreement, right? Ultrasound 1 to the OMM practitioner 2, it's about the same thing. 0.14, I don't know why that is. 31.8%. That makes no sense. How in the heck did that go higher? Oh, maybe, yeah. Weird. Something's funny with that. Anyways, ultrasound 2 to OMM 1, 37.9%, 0.06. Ultrasound 2 to OMM 2, 30.3%, so 0.11. So then the OMM practitioners agree about 31% of the time. So it's 0.05 Cohen's kappa. Yeah, so the numbers basically show that these things don't agree consistently. Therefore, to be used for the form of diagnosis, which is a static diagnosis about positional asymmetry, you're not getting good agreement. So that could mean a few things. That could mean that static positional asymmetry is useless, and you're not going to get things to agree on it, whether it's ultrasound or people. It could mean that what you're measuring is just bony asymmetry, because you're not asking it to move, or you're not inducing movement into it, other than wiggling somebody's head to try to move their T-spine. It could just mean that, they did stuff the same way, so I don't think it means that there was procedural variance. But in a basic way, if I can't even get the ultrasound to agree on the diagnostic to reasonably skilled ultrasonographers, if I can't get them to agree on the diagnostic, then maybe the diagnostic itself is kind of useless. It's not going to be that useful to me. What this does, I have a general framework of considering that it is not this specific naming of a structure that makes a difference. It's whether or not it moves, because the thing that I can identify is something that does or does not move, especially when compared to its paired structure on the opposite side. I don't need to name it. I need to find it. It can have lots of different names, and people can disagree about the names or the locations, but we could probably agree on whether or not it moves, whether or not it yields to pressure or does not yield to pressure, whether or not when requested to move actively, it does or it does not. We're more likely to agree on that than we are identifying the specific thing and then diagnosing in a particular way. So the thing that I'm going to take away from this broadly, based on the data that I see, is that the model that I have, whereby I consider presence or absence of movement at the top of my diagnostic hierarchy, because it's the thing that I can observe most honestly, is going to be more important than what a particular transverse process is doing. Also, like, I don't know how well these people are interpreting the transverse process themselves, how their fingers are, because like there's no measurement of asymmetry in their fingers or asymmetry in their hands, things like that. So there's challenges with it. We got some more. Okay, I'm going to tell you the highest level of agreement, period, with sub-comparisons, ultrasound 1 and ultrasound 2 at T5, there's a 0.44 Cohen's kappa. So that's decent agreement at 63.6% of the time at one vertebrae. Whatever. Like comparison of ultrasound and OMM findings, T2 to T4 spinous processes. Yeah, like there's nothing here. There's just no agreement. The inter-examiner agreement is just trash. Transverse process. Yeah, there's nothing here. This is like an empty shirt or an empty suit. There's lots of data here. Like there's lots of data. I want to see what they say in the discussion. Or actually, you know what? I'll just see what they say in the conclusion. In conclusion, this preliminary study of an asymptomatic population revealed, as shown via Cohen's kappa and Fleiss's kappa, that there is low to moderate inter-examiner reliability between sonographers, low to slight inter-examiner reliability between osteopathic physicians, and low inter-examiner reliability between OMM palpatory examination and ultrasonographic evaluation of the thoracic spine. There is, however, slightly higher reliability at T5. I'm going to use an ultrasound just for T5. Like, no. The findings align with the main role of osteopathic palpatory examination as a clinical tool, the diagnosis of asymmetrical somatic dysfunction with the intention of treatment. This study was designed to contribute to the growing literature surrounding osteopathic medicine with the hope that the methods and results reported may help contribute to the foundation of future studies examining osteopathic palpatory examination and treatment, as well as the role of ultrasonographic examination in clinical practice in teaching diagnostic palpation skills to osteopathic medical students. Future studies looking at ultrasound and OMM exam correlation on both asymptomatic and clinically symptomatic population may prove to be an easier way to analyze validity and calibrate the two relationships between ultrasonography and OMM structural examination. Given that previous studies performed on other regions of the spine utilizing ultrasound to assess pre and post-treatment measurements yielded positive and significant findings. Further study of inter-examiner reliability on the thoracic spine pre and post-treatments may also yield significant findings that may be beneficial to the osteopathic medical field. I haven't necessarily looked at those studies, and I likely should, so there may be more there, but a lot of times inter-examiner reliability, with what I've seen, you're getting kind of moderate. Moderate is like the 0.4 to 0.6, something like that. So you're probably looking at 60-ish% agreement. That I wouldn't call that diagnostically acceptable, right? I'd call that pretty rough. Yeah. So because I have a pre-existing model that guides how I'm going to interface with a patient, I want to know what is not moving. I do not want to know what is asymmetrical when I poke it. I want to know what is not moving, because my intervention is based on applying movement to a region. I move something when I find it not moving. Now, there's a variety of ways in which you can do that. You always have to pay attention to how the patient responds so you can adjust the application to how they're responding. If they're responding poorly, you don't do it that way. If they're really not fighting back, they're not protecting themselves, they may not feel much, then you're in an acceptable range because you're not going to cause any harm. Or your likelihood of causing harm is exceptionally low at that point, rather, because you're not eliciting any protective responses. So I kind of don't care about the static asymmetry. The static asymmetry does nothing for me. So while for the claims that they're making, the safer agreement, inter-examiner reliability, they did a decent job because they did proper training, they had coordination, the examiners did the same thing. And they still didn't get good results. So why am I going to spend time with this? This doesn't seem like something that is going to be a particularly fruitful avenue of examination in future. I would have to see the other stuff like the lumbar region and the cervical region. Maybe it's better. If it's better, then I can calm down a little bit. But right now, this seems like a waste of time because I don't care about the specificity of the structure. I care about what moves. So one of the heuristics I use is specificity is not the number one necessity. Movement is. I care about movement. Can I find if it's not moving? And if it is not moving, can I work on it in a way that the patient accepts and does not, essentially, maybe a better way to put it is does not reject in the form of a protective response. If I can do that, I seem to get a positive range of results with essentially no negative results. So, yeah, you can keep spending money trying to figure out if you get good inter-examiner reliability or inter-examiner agreement on something that I'm not going to use anyways in the form of static asymmetry. I'm not going to use it anyways. I'm not going to waste my money on an ultrasound head. And also, legally, I can't use the ultrasound head to make any claim anyway, so it's a waste of money. That's going to be the case for most jurisdictions around the world, whereas in the American context, I guess it makes more sense. Like, I get it, but this doesn't seem like it's going to be exceptionally fruitful, at least from that one study. If I looked at the other ones within the cervical and lumbar regions, maybe they look better, but my confidence is not high in that. Anyways, if you have listened to this far, thank you for listening. Hopefully you've learned something, and we will talk again soon.